Okay, thank you, everyone. It is an honor to be here, and without further ado, I'm going to get started. We are going to talk today about some concepts that may be new, may be familiar to some of you. I hear that most people who took the pre-conference question related to trans and gender-affirming care got it correct, so I might be preaching to the choir. But I hope that you will take something you didn't know away from our talk today. We're going to talk about culturally safe and gender-affirming patient-provider interactions and how that has an impact on health outcomes for trans people. We're going to talk about gender-affirming interventions, briefly, hormones and surgery, but we'll talk more about that in the breakout session later this afternoon, but how we need to be taking all that into consideration in the context of HIV management, and then talk about implementing some best practices in clinical settings. So, our first question, everyone has your audience response things ready? I know everybody just came from lunch. Who knows how many trans adults are estimated to be living in the US today? 250,000, 500,000, 1.4 million, or 4 million? All right. Getting more answers in. Okay. Yes, most people got this correct. Roughly 1.4 million. However, we are not exactly sure because this is not being collected routinely. So these are all estimates. And when we say the word trans, what we mean are individuals with a gender identity and expression that does not align with the sex that was assigned at birth. And so there's actually many different terminologies and ways that people might refer to themselves, folks of trans experience. It might include non-binary or genderqueer, male or female, trans woman or trans man. And so generally when I use the term transgender in this talk, I'm referring to a very diverse group of people, and sometimes we refer to it as the trans umbrella, so sort of an overall catchphrase that is actually referring to people who may not use these words to describe themselves at all. And another reminder that everyone in this room I'm sure knows well, but I always have this in my slides, that we're talking about gender identity, which is very different from sexual orientation. And so what our estimates are telling us is that it's about 1.4 million trans adults in the US. And just to put this in perspective, it's slightly more than the number of adults and children living with type 1 diabetes. And so those of us doing HIV care are probably more familiar with and working with trans folks than people in general primary care. But if you have not already, you will certainly be caring for someone of trans experience. Trans people often are navigating stressful realities due to stigma and discrimination. The way that our society has structured gender in a binary, assuming that gender is attached to sex assigned at birth with norms and all sorts of hosts of things that get attached to gender, this shapes the environment. And for many people, this makes for unsafe realities in their workplace, their homes, and many public spaces. So just some statistics: when compared to cisgender US adult population, trans folks are 2 times as likely to be living in poverty, 3 times as likely to be homeless, 3 times as likely to be unemployed, have a 9 times higher suicide rate compared to the general population, and higher rates of sexual and physical assault. And so what this means is that folks are coming in with experiences of trauma. And unfortunately, these experiences also happen in the healthcare setting. How many people in your formative training learned anything about trans healthcare? Very few of us, right? And so it's actually seems low to me that about 50% of trans people reported having to teach their healthcare provider about trans healthcare. 20% people in this large national survey were actually reported having been refused care. I still hear about this all the time. 28% were subjected to harassment in healthcare settings or had postponed care because of discrimination or because of fear of discrimination. So delaying care, not seeking out care, this is a reality that we as healthcare providers are trying to do something about. But this is what we're, the environment that we're working with, the experiences that people are having in our healthcare systems. We know that HIV among trans people in the United States is now being more accurately captured by HIV reporting, including information about gender identity and sex assigned at birth. So we have roughly 2,300 trans people received an HIV diagnosis between 2019 and 2014. The majority of these were transgender women. 15% were trans men. They did not capture non-binary identities, so we're not quite sure for folks who actually don't identify as male or female where they might fall. And about half lived in the South. HIV among trans people is disproportionately impacting people of color, which we see similarly in the cisgender population, and significantly disproportionately impacting trans women globally and here in the United States. So some data about the prevalence, most of this is estimates and pooled data, but we know that trans feminine individuals have some of the highest concentrated HIV epidemics in the world. Among trans men, we have less information, and this does not mean that trans men aren't at risk for HIV, but the data that we do have is limited and is showing much lower rates. The studies, the one systematic review we have only found 6 studies, and one of the studies only had 1 person. We're probably underestimating some trans men who may be at high risk, and so this is important to keep in mind, especially for those of us also doing HIV prevention work. And the take-home message, if nothing at all, from this talk today is that gender-affirming care will improve healthcare outcomes across the board, including HIV outcomes. We have a couple of different studies on this slide here that looked at our continuum of care for HIV and found specifically among trans women that lower proportion of retention in care was occurring among trans women compared to cis women and cis men. But when people were engaged in care, they had similar virologic suppression. And then at these 9 demonstration SPIN sites, we found that about half of trans folks were on hormones, and if their HIV primary care provider was also their hormone prescriber, they were 3 times more likely to have a suppressed viral load and to be engaged in care. So we know that this works to do gender-affirming care and hormone care alongside HIV care. And similarly, Jay Sebelius has done a lot of work on something called the gender affirmation model, showing that lower levels of gender affirmation in someone's life leads to worse health outcomes, and greater levels of gender affirmation leads to improved health outcomes. And so this model was recently tested and specifically related to virologic suppression, finding that when trans women were receiving gender affirmation throughout their life, and I'll tell you what I mean by that in a minute, and were empowered in their health care, this mediated the effect of other types of discrimination that they were experiencing on their viral loads. And so we can actually do something about the high levels of discrimination and stigma that are impacting trans women, especially by incorporating gender-affirming care into our HIV practices. So I'm going to propose for you some frameworks of how we can do this. The first is a framework of cultural safety. Most people in this room have probably heard about cultural competency or cultural humility. And cultural safety is even broader than that, to really take the perspective of making sure that healthcare is safe and free from harm, considering that people who are marginalized in society are going to also experience unsafe experiences in the healthcare setting, because our healthcare setting is a microcosm oftentimes of these larger structural issues. And so cultural safety encourages us to care for the unique experience of each person. Not everyone's story is going to be the same, and encourages us to become aware of our own biases. As a cisgender person, I don't know what it's like to be of trans experience, and that is something I must continually be checking myself about, and how I might be assuming, making assumptions, or bringing my own implicit bias to the healthcare encounter. And that will help us avoid perpetuating harm, especially unintentional harm. And then we also need to understand that we're working within these structural systems and create dynamics of power that impact the healthcare encounters. And the other piece of this is managing uncertainty. And so another thing I just want people to think about, and you don't have to raise your hands, is the first time you worked with a trans person in a healthcare encounter and maybe didn't know exactly how to answer a question they had or what to do exactly because maybe there weren't clinical guidelines at that point. And so Tonya Poteet did this study some years ago now, but it's still, I think, very important. When healthcare providers who were trans healthcare providers noticed that they were uncertain about something in caring for trans people, that they managed that uncertainty with a stigmatizing response. As healthcare providers, we're expected to know the answer to as many things as we can know the answer to, right? And so because of this power dynamic that's set up that we're supposed to have all the answers, sometimes blaming and shaming and othering and discriminating happens even inadvertently. And so what I encourage all of us to do is take a few moments when you're back in your clinical settings and look at where we might be having some resistance to acknowledging that the patient sitting in front of us is actually the best authority in their own life, and that means we have to relinquish some power. What do I do when I'm uncertain about something? When people are coming and asking me for something that I hadn't heard about before or wasn't in the guidelines? And where maybe have I responded consciously or unconsciously with a stigmatizing action or reaction? And so we bring all of this then to the gender-affirming care model, where what we're doing is affirming and recognizing one's authentic gender across these 4 domains. And some of these are more structurally complicated than others. Socially, it's as simple as using the name and pronoun that someone tells you is their name and pronoun. And that also, though, can mean institutionally that needs to happen in the electronic medical record or on paperwork. Psychologically, this is allowing for self-actualization, preventing internalized negative beliefs, connecting people to behavioral health services that are affirming. Medically, this includes medical interventions like hormones or other bodily modifications or surgeries. And legally, this often involves a process of legal changing of the name or gender marker on identity documents or health insurance cards or things like that. And so there's sort of this, the way I think of it is this 3-pronged approach to doing this when we're in a clinical setting. So in our clinical environment, this means our intake forms, the very first thing that people usually see when they're walking into our offices, and these might be electronic now, have a place for people's name and pronouns, have a place to then also identify the name that they have on their insurance card, because with billing it becomes a whole mess sometimes. Explanations about why we need to have all this information, and 2-step data collection, which I'll show you a sample of in a second. So all of these things in our institutions in the clinical environment can create gender affirmation across those 4 domains. This also includes making your clinic or your organization a safe place for trans people to work. It might mean changing HR policies or making sure that you have bathrooms for both clients and staff that are gender neutral, or policies that allow people to use the bathroom that aligns with their gender identity. So 2-step gender identity collection, most people are very familiar with this now. How many of you are not doing this in your clinical practices? All right, most people are. And so we all know that this works, that collecting the safe information works, and it is already starting to provide us with much more accurate data and information, but also helps us in the clinical setting as well. And so with patient-centered care, this is the other piece of our gender-affirming care model, is care that's respectful and responsive to patients' preferences, needs, and values. It's ensuring that the patient's values guide the care, and it really is about prioritizing community engagement and leadership. If you're not already seeing a lot of trans people in your clinical setting, I'm sure that they are in your area, and I would encourage you to reach out or set up a way that you can learn what it is that trans or non-binary people in your setting or in your clinic need and want to make your space more welcoming for folks. And patient-centered care is also about establishing trust. This is my favorite definition of trust, which is choosing to make something that I value vulnerable to another person's actions. This is actually what happens every time someone walks into a healthcare encounter. Anytime any of us become patients, we notice pretty quickly what it feels like to make something vulnerable, our body, our health, vulnerable to another person's actions. And so then distrust is when what's important to me is not safe with someone else. And so looking to establish trust is what most patients are doing, and trans folks in particular are watching to see that this is happening and are going to sense that this is happening through all these different ways that we can be affirming of their gender, their authentic gender. So the next thing we're going to talk about is communication and language. And this might be too easy of a question, but we'll see how we do. So the following would be an example of gender-affirming communication and language. First is saying, hi, my name is Linda, and I use she, her pronouns. What name and pronouns may I use for you? The second option would be, thank you, sir. The third option would be a sign that says, welcome to the Women's Health Clinic. And the fourth, do you have sex with men, women, or both? Okay. Yep. And why would it not be the final question, sex with men, women, or both? And that's assuming that gender is binary, that there is only a male or female gender, and we know actually that gender is on a spectrum, and many people don't identify as male or female or both, and so removing sort of these gender types of language, this gender type of language actually is affirming whether or not we're working with someone who we know is trans or not. And so communication and language means often in clinical settings that we have a protocol where we're asking for and documenting name and pronouns. The documenting part gets a little more complicated depending on what your EMR looks like. Is it in a place where everyone can see it and use name and pronouns consistently and accurately? But it is also about avoiding this language that might assume binary gender. And also understanding that medical terminology for body parts might be different than how folks experience their bodies or their gender. And so asking people before doing certain procedures or asking people what language they might be using as a part of the exam can help with that as well. So the final piece is advocacy. And so what we're talking about with advocacy is really working within some of us these very large systems where our interpersonal interaction with someone is affirming, but multiple steps along the way of them getting into that exam room with us or getting into our clinic, they may have encountered stigmatizing interactions or situations that were not affirming. And so this sometimes means a large overhaul of various policies and procedures. Sometimes it means explaining why the patient summary sheet we print out or the referral is going to have the legal name on it because that's all our EMR can do, or figuring out how to change that. I mean, there's so many different possible scenarios here of what we could do as clinicians when we're noticing things like that to step in and say, okay, we need to change this policy or this procedure or this workflow because it's not affirming. And so I'm going to skip ahead with, in the interest of time, with some of these other ideas. But those of you already doing work with trans folks probably have experience with this already. And so it's this ongoing process, right, of gender affirming care and ongoing self-reflection. And how can we keep creating spaces that are safe for trans and non-binary people to come and access care, because we know that it improves health outcomes across the board. And then the other piece, which even though some of that might be reviewed, maybe this piece is what people are more here for, is understanding what our current best practices is for gender-affirming medical care. We know that right now we have a current DSM diagnosis phrase called gender dysphoria. The WHO is going to be adopting a diagnosis of gender incongruence. Whatever we want to call it, when someone has an incongruence between their gender identity and their physical characteristics that causes distress, gender-affirming hormones and or surgeries are medically necessary. This is best practice. This is statements across the board from every professional organization, and it is now covered more and more by insurances and protected somewhat from discrimination and from various exclusions. Across the world, we generally follow the WPATH Standards of Care 7, which are available at the wpath.org website. They are currently under revision. The Standards of Care 8 will be out sometime, maybe next year. We're working on them diligently. And so this is the place to turn when you're looking for what the best practices are in providing gender-affirming care. The current WPATH Standards of Care do not have details about clinical guidelines, so what dose do I prescribe, or when do I do a mammogram, or when do I do a DEXA scan, or all these types of things. So this is where I encourage you to turn to these other two sets of information, the UCSF Transgender Care Guidelines, which are now housed at this website here, that Maddie Deutsch and a bunch of us also contributed to. These are geared for the primary care provider. And we also have the Endocrine Society Guidelines, which are written by and for endocrinologists, but also has a lot of useful and helpful information. We also have something called the TransLine, if you're not familiar. If you are a practicing clinician and doing a little bit of hormone prescribing, but sometimes find yourself unsure of what to do, please use this resource. We have a set of hormone prescriber protocols up here. We have information about how to set up your office, how to do billing, how to write letters for surgeries that insurances will require, and consultation services where you can submit a question and someone will reply to you via email in about 24 hours or so. So all of these things are available to you. And I give you all of that because I'm encouraging all of us as primary care providers, as HIV providers, to be offering gender-affirming medical care in our HIV settings, because we know this improves health outcomes and because hormone care is best practice, is medically necessary. So when we're doing medical gender affirmation, hormone therapy specifically is guided by the patient's goals. When someone's goal is to have masculinization, we use testosterone formulations and doses that are similar to hypogonadism, something that most of us in the HIV world are quite familiar with. When we do feminization, we use estrogen either alone or in combination with an anti-androgen, and that's usually spironolactone. Medical affirmation can also look like surgical interventions. Many surgical interventions, according to the WPATH Standards of Care, have requirements. Sometimes certain surgeries, someone has to have been on hormones for a certain period of time, has to have certain BMI requirements, letters from mental health professionals. And in the interest of time, I only had 30 minutes. I can't get into all of that here. This could be a 3-day-long talk. But all of this information is in those guidelines that I gave you. A few things that I want us to think about in the HIV world. Some potential comorbidities. The first is osteoporosis, especially for trans feminine people or anyone who's had a gonadectomy. We might be concerned about osteoporosis alongside with the potential risk of that with someone living with HIV. We know that trans women might have a lower bone mineral density even prior to starting feminizing hormones. There's been some data on this, mostly out of Europe. We think this might be due to, in general, lower physical activity or lower muscle mass, lower vitamin D levels. But this should be something that's on our radar as HIV providers who are also doing hormone care. Similarly, cardiovascular disease is everybody's concern all of the time. So many possible risks, but we do have some evidence that estrogen may increase risk of cardiovascular disease, and of course we're also concerned about blood clots. And so what the main take-home message is that transdermal estrogens are probably the safest based on the data we have now. I should have had a blanket statement. We need more data about all of this. But what I'm presenting to you is the best expert and the best data we have available, information for you to take home. The other thing that's being looked at now is how minority stress and trauma is impacting cardiovascular risk as well. And so this needs to be teased out a bit, I think, from putting all of the blame on hormones, that there's probably other factors that go into that. Tobacco use, substance use, so many things that trans folks are at higher risk for that are related to minority stress as well. And so, all right, we have our next ARS question. Make sure you're still awake. Feminizing hormone therapy for gender affirmation is contraindicated with most ARVs because of the drug-drug interactions. Is this true or false? What do we have to worry about with drug-drug interactions? I bet you all know this one. Yeah. Yep. Correct. Feminizing hormone therapy for gender affirmation is not contraindicated with most ARVs. So what do we know about this? Well, the data is lacking again. Most of the data we have is based on studies with ethinyl estradiol, the medication, the oral hormone contraceptives, which is not what we use in gender affirming therapy. Do not use ethinyl estradiol. We need to have a dose to reach our goals. We use 17-beta estradiol for gender affirming care. But we're still concerned potentially what's happening because everything's going through cytochrome P450. It's similar to most of our ARVs. The data we had up until November 6th of this year is that more likely than not what would be happening with most of our ARVs is that the estradiol levels would probably be lower, unless you're using fosamaprevir still. And so this is a too hard to read little snapshot from this excellent overview article that Dr. Radix and others put out in 2016. If you're wondering at all what might be going on between estradiol, again, this was all ethinyl estradiol being studied, between ethinyl estradiol, and then maybe we can extrapolate that to what we're doing with gender affirming hormone care. We see no effect for dolutegravir at least, and in these studies no effect with tenofovir, but there's been a recent PK study that came out that I don't have in these slides because it was so recent, looking at PrEP and hormones, because this is certainly a concern. And there's definitely there's still some questions about whether or not estradiol is lowering tenofovir levels. And we don't have PK data on TAF, on our newer PrEP regimen, but this is to be followed and to be continued and to be watched. The take home for PrEP for trans women is make sure that they're taking it every day. That's the most important thing, not the dose interval PrEP treatment. And so, key points to take home is that HIV itself is certainly not a contraindication to gender-affirming interventions. People living with HIV who have functioning immune systems can certainly pursue surgeries. There's not major drug-drug interactions that make hormones contraindicated. Combining hormone therapy into HIV clinical care streamlines the management of both things and increases access to care and improves virologic outcomes. We want to watch out for osteoporosis and cardiovascular complications in trans people who are living with HIV. And we as HIV providers are well equipped to do this work. And if you're not already, I encourage you to go back and take this information, all of the guidelines that we have available, and make your space more affirming and welcoming to folks of trans experience. 30 minutes is not enough, since most of you here didn't get this in your formative education. So there's a lot of educational opportunities available to you. Especially I encourage you, if you're looking to implement some of these changes in your clinic, looking into the Trans Health Echo program, which is a comprehensive training for clinical sites interested in improving access to care for trans people. There's a lot of conferences. The National LGBT Education Center has excellent information about PrEP among trans folks. And I also have a list of reading for you. And I made it without this light turning red, so I have plenty of time for questions. Thank you.
Great, thank you, Linda. Have a seat, if you don't mind. Very nice. So on a lot of levels, I think most of us have become pretty comfortable just dealing with the pronouns appropriately. In our clinics, I think we do pretty well. The challenge, I think, is making that leap to feeling comfortable prescribing the hormones. And as I look at your slide, I think, that's not too difficult. I mean, it looks pretty straightforward. But is it the type of thing we can just start doing with confidence? And how do you suggest that folks who haven't done this before get started?
Sure. I think that the most accessible set of guidelines and information, which, I mean, I remember when I first started as an HIV provider, I was sitting out in these audiences at IAS USA Talks, and I thought, how am I going to know what to do? I looked at the guidelines, right? And then it kind of spells it out for you, and you're like, okay. And so that's what we've tried to do, especially with the UCSF guidelines, make them easy to use for, and I know y'all are busy, for busy providers. You know, it's not like you have an extra hour for the first trans person that you're going to prescribe hormones for. You kind of have to figure it out. So use those. I would definitely recommend use those guidelines and use the Trans Health, the Trans Line consult service.
Okay. So a more complicated question is, a patient is very enthusiastic or wants to have a surgical procedure for gender change. A lot of controversy about it, ranging all across the spectrum. How many patients have you had in that situation, and how did you manage that?
Well, there's a whole host of different surgeries. So we can be talking about everything from facial feminization surgery, which would be sort of a plastic surgery type of procedure. Many people access plastic surgery without needing to have a letter from a mental health provider. And that's everything. And then there's chest masculinization surgery for transgender men, which is a very common procedure. I've had lots and lots of people access that procedure. And then often the more complicated procedures are genital confirmation or genital affirmation surgeries, either vaginoplasty or phalloplasty. I think that most of us will have differences in our patients' ability to access all of these surgeries depending on where we live and where we work, because state by state, the access is really dependent on insurance coverage, access to surgeons who know how to do these procedures, Medicaid coverage, and things like that. So where I work, we had an exclusion recently lifted for Medicaid recipients. So I haven't had many people in Wisconsin being able to access surgeries until a couple of months ago. Okay. So it just kind of depends where you're at.
Okay, a couple other questions here. Do we have the same recommendations for transgender populations regarding estradiol, et cetera, for women who are over 40 who smoke? Is it a concern about the cardiovascular?
Yes. Yep. And so any, the whole pileup of cardiovascular risk factors or risk factors for blood clotting, we would also be concerned. So women over 40 who smoke would be, I would be recommending those folks to use transdermal estrogen because it is not so far, and we have a little bit of data in trans women specifically looking at transdermal versus oral, that transdermal is definitely safer and does not increase risk of blood clots.
This question says that injectable estrogen prices are now greater than $200 a vial. Yeah, what do you do about that?
There's a whole bunch of things going on with injectable estrogen. There's also a shortage sometimes. Does anyone run into that? Yep. I use GoodRx, not to advertise for them, but the various discount prescription options that are out there. But yes, cost of medications is certainly an issue, and injectable estrogen tends to run a little bit more expensive, although the vial can last longer. So sometimes it actually ends up to be about the same price at the end of the day.
Okay. This question's a specific patient question about a transgendered woman who's on spironolactone and finasteride and still has a testosterone level of over 500. Are there tricks to getting the testosterone levels lower?
Yeah, and so A GnRH analog would be the trick, but it's
Yeah.
very expensive. But that's the most effective anti-androgen we have. And it's okay to use in adults. It's certainly in the guidelines. It's just difficult to access. I have had folks in that scenario who choose to have orchiectomy, and then that obviously works. But sometimes you'll find different clinicians trying different things, maybe changing the formulation of the estrogen. So for example, someone's on oral estrogen and you're having trouble getting testosterone suppressed, switching to either transdermal or injectable sometimes gives a little extra boost to the HPA access, and then can slow down the body's production of testosterone. Those are all just tricks. We haven't had a study to answer that question, unfortunately.
All right. What about maximizing the injectable estrogen? So right now, say it's 60 milligrams a month. Is there harm in going higher, like to 80?
Like trying to stretch out because of the shortage or whatever, the cost.
Just
right. I mean, I found, now this is just anecdotal, but everyone kind of is going to metabolize the injectable meds differently. And so I find that people we do the best to actually do smaller amounts every week instead of large amounts once a week, once every 2 weeks or once a month. And so I would actually suggest going that route, maybe not doing as much further apart, but less, and maybe you would need less overall, but it really is it's really patient dependent. And if they're on an ARV that could lower their estrogen levels, you got to be taking that into consideration too.
Okay. This is a question about the estrogen patch, because in its use otherwise, when used continuously, was associated with a higher risk of DVT. How do you mitigate those concerns?
Right. So we want to be using the synthetic 17 beta estradiol, it's not the oral contraceptive estrogen patch. And so we're certainly, that's the culprit there.
Yeah.
So yeah, just make sure you're using the similar formulations to postmenopausal hormone replacement therapy. That's what we're using in TransHealth.
Okay.
Yeah.
So how can we address increasing comprehensive medical care, mental health, and primary care hormones without increasing inequity with the insurance system? In other words, you keep doing all this extra stuff, but maybe there isn't coverage.
Not getting reimbursed for it.
Is that what you use your case managers for?
Yeah, and get creative with billing. I mean, I guess it really depends on your setting. But most insurances are reimbursing. If we're in HIV settings, in Ryan White settings, yeah, it really just depends on. I feel like that's so complicated about what the level of access might be.
Yeah.
But I think the goal would be, and hey, you got plenty of data to take back if someone's pushing back against you doing this work, that HIV outcomes are going to be better. If we have these 3 studies now and even more coming down the line, HIV outcomes are going to be better when we integrate gender-affirming care and hormone care into our HIV settings. So take that to the insurance company or
there you go.
your funder, right?
All right. Is there an age limit on when you would prescribe hormonal therapy? In other words, is there a point where you say, increased risk benefit?
How old?
Yeah, how old? Yeah.
Right. This is a good question that we don't have clear guidance for in the guidelines. So I figured this question would come. There is not an age limit that most experts are saying, well, that's just not worth it, because the point of gender affirming care is gender affirmation. You are going to have less physiologic response to hormone therapy, very likely the older someone is. And you have to take into consideration other issues, so other comorbidities, cardiovascular risk, et cetera. But for example, I have a patient right now, is not living with HIV, but is 76 and started hormones at 60. We're doing it in coordination with her cardiologist, because she had a history of an MI, and everything's great, and she's very happy and living living a very happy, her best life. And so,
Yep.
so it is okay to do, just use your clinical knowledge and
So
coordinate.
it's all individualized. We have time for just a couple more questions. So specifically, again, I think this is transgender women, how do you counsel about hormonal effects in terms of risk for cancer or DVT? I think you addressed the 17 beta, but
Yep.
what do you say specifically?
Yeah. So when it comes to breast cancer, again, I'm going to say this based on the data we have, which is not the best gold standard data, but at least it's something specific to trans women. Most of the data we have about breast cancer is from the VA system, because actually they've been collecting gender identity information for a while. And we did not see any difference in risk for or incidence of breast cancer among trans feminine people compared to cis women. In fact, it's probably less because of the period of time that people have been exposed to estrogen.
Okay. And we do have one theme of the last one, even though we're a little bit off on time, but the two questions related to finding access to surgery when there's no insurance coverage. I'm talking more general or gender affirming in that way. So are there resources or places that you can, where you refer people when you don't have access otherwise?
You mean like access
No
like
insurance.
money?
Yeah,
Or
money.
surgeons?
Money.
Right. Yes, I mean that's the challenge. There's a few small scholarship funds I know of in the States. There's certainly some information on the TransLine website about some of these different things, but it's extremely limited when someone's in a space, because if you're in a state or an area that doesn't have good insurance coverage, you probably also don't have surgeons in your area,
probably
and so
right.
you're going to have to travel.
Funny
And
how
so-
those things go
yeah.
hand in hand.
Right.
Great.
Yeah,
Well,
so we're still certainly running into access issues when it comes to surgery.
great. Thank you very much.
Yes,
Wonderful
thank you.